My name is Lindsay, and I am doing a presentation for my bachelor's degree. It had to be something about leadership, and I am involved in the nurse staffing committee here, so that's what I wanted to present to you guys today. The purpose of the nurse staffing committee, it is provided to us by the Nurse Staffing Improvement Act of 2021. Every hospital has to now have a staffing committee because the staffing matrix is different at other hospitals because they require different patient demands. So because they can't set out one straight staffing plan for all hospitals, every hospital has to have their own nurse staffing committee to form their staffing plan. And overall, it's going to improve team assignments based on patient acuity and not on volume. And overall, we hope to see improvement in HCAHPS scores as well. So some SMART objectives. SMART stands for specific, measurable, achievable, relevant, and a time frame. So the two objectives I came up with for the staffing committee is to create a safe staffing standard based on patient's acuity and plan of care during their stay at JCH, and to provide each nurse with a safe patient-nurse ratio during every shift for the overall goal of maintaining patient safety. Nurse-patient ratios have been a common topic lately all around hospitals just because of COVID and now a staffing shortage. So it's really important that we have enough staff to maintain patient safety. So the nurse staffing committee is composed of RNs from inpatient departments, including supervisors. Right now we have one supervisor who attends our meetings. And per the Nurse Staffing Improvement Act, 55% of the committee has to be composed of direct inpatient care nurses. And a chair member has to be also a direct inpatient care nurse, and we do have that. Per the act, we have to meet at least 6 times a year, and we try to meet at least once a month to stay on task with everything going on. And the nurse staffing committee is a way for the hospitals to be held accountable for their nurse-patient ratios because we form a staffing plan, and if the hospital doesn't go off that plan, that's on them, not on us. So responsibilities of the committee: we review and update the JCH written staffing plan. We review the HCAHPS scores. If we are in the green or if we are in the red or the yellow, we need to talk about why, and if that's a staffing concern, that's where we need to come in and propose suggestions to improve those scores. Review recent ProCare reports, choosing an acuity indicator. That's on the staffing plan that every hospital has to have an acuity indicator, and we have an acuity tool now, which I'll go over later. Provide suggestions to maintain the best patient safety, and provide an annual report to the staffing committee of the board. So twice a year, the committee also has to form reports to give to the RNs to let them know where we are, what we've been doing, and how it affects them. This committee affects the RNs directly. That's why we want a lot of RNs involved. Okay, why did I choose the staffing committee? Besides that I'm a member, I don't want to see turnover of nursing staff. This place is like a family to me. I don't want to see nurses leave. We're already at a shortage. I want everyone to enjoy the environment that they're in. And so if we're staffed properly, that's going to reduce the stress of the nurses, and it's also going to reduce medical errors because there's more staff on board, nurses are not stressed out, and they can have more focus on their patients and what they're doing. So the overall goal of the staffing committee is to provide patient safety and a comfortable nursing environment for the staff. So the committee's impact, as a member of the committee, I do feel like that my voice is more heard because I'm part of the committee. Like during the meetings, everyone gets a voice and everyone is encouraged to come to these meetings. New RNs can join all the time. So if you have a concern, if you have something that you really want to push for, it's best to come to these meetings, that way your voice can be acknowledged. And if you don't come to the meetings and something goes wrong, we do have variance reports that we are starting so that RNs who do not attend the meetings can also have their voice be heard. Overall, this committee provides positive feedback, and the goal is to provide safe staffing. And if nurses know that their voice is being heard, their concerns are being heard, that's going to increase the morale of the nursing environment. So from a peer-reviewed article I found, it's how to determine the right number of staff. If we want quality and efficiency of care, we have to have the correct number of staff to do so per each shift. And it says staff sickness does not occur uniformly, but rather in clusters. We have seen that completely with COVID. And I'm glad that it mentioned this part. It said orientees do not count when considering the staffing grid for that day. Sometimes we see that supervisors or managers think, okay, I can put someone on call because someone's orientating today. That's an extra set of hands. But really it's not so much, because they're less experienced and they might not be able to meet that high of demand that as that RN that you just put on call, who knows the system, who knows the plan of the day. So orientees are here to learn, not to be counted in the staffing grid. So from the American Journal of Nursing, it explains 3 dimensions of nursing burnout: emotional exhaustion, cynicism, which is another word for hopelessness. We saw that through COVID. We do for these patients, and it's sometimes not enough. And a low sense of personal accomplishment. This especially happens if we're not staffed properly. We just feel like that we didn't do enough for our patients whenever we go home that day, and that's not how a nurse wants to feel. We're all in this field to help our patients, not feel like that we aren't giving them enough of our time. So how to prevent the nursing burnout is to lower the nurse to patient staffing ratios and allow nurses to spend more time with their patients. So the acuity tool, I passed out packets for all of you because I know this is really hard to read up here. So this is the acuity tool that we currently have, and the goal of it is to provide equal team assignments. So you might not have the same number of patients as the RN next to you, but the acuity number is going to be as equal as possible. So we need to, we have been filling these out every shift, and we need to keep them, because if a variance report is filled out, which I'll explain in a little bit, we need to go back to what the acuity was for that day and see what happened staffing wise. If it was an issue or if it was an okay staffing day. So to explain this acuity tool, it's pretty simple. If your patient is on telemetry and they also have a Foley, that's 1 point each. So that's a total of 2 points for that column. If they're a fall risk, that gives them 2 points, so that's automatically 4 points. And then you just keep going. This one does have high fall risk and fall risk together. One's a 2, one's a 4. So I feel like we need to adjust that, because that's gonna cause some confusion with people. And sometimes people, staff members don't want to fill this out. They say they don't have time to fill it out. So the staffing committee is revising it to make it quicker and easier to fill out to improve the compliance. Excuse me. So this is a staffing acuity tool from another hospital that I found, and I like it a lot better. I plan to present this acuity tool at the next staffing meeting, because if you look at it, instead of counting your patients 1, 2, 3, and 4, this gives 0.2, 0.25, and 0.33. So it says on here you don't want your RN to have more than an acuity of 1 for your team. So that could be 5 easy patients that are 0.2, or that could be 3 really hard patients that are 0.33. But this says that it cannot exceed 1 for that nurse's team of patients for the day. So I also like this because it says somewhere on here, if the acuity on the floor is greater than 2, that's when you get your additional 3rd nurse. So this staffing grid is more structured, and I just like it a lot better. And it's a lot easier to fill out. There's 3 simple columns. If your patient is in that column, that's what their acuity number is. So I think this one would increase the compliance of the nurses to fill out and follow, and also increase the compliance of like supervisors and managers. It's easier to put someone on call if you have this and say, well, the total acuity is less than 2, we don't need that third nurse. Now there's structure to it. So the staffing plan, that is also something I've passed out. So the staffing committee has to review and pursue the staffing plan that we develop. It goes over the complexity of the patient's needs, physician preferences. It explains the rules for staffing. How can someone be put on call? Can someone float? Can they cross-train? That's all in here. This, per the Nurse Staffing Improvement Act, it is required that we post this for the public to see. So we plan to post it on our website, and then we will also post it in our bulletin boards around the hospital. That way, outsiders know our staffing plan. And this staffing plan is just a way to hold hospitals accountable for their ratios. And in here it says that you must have an acuity model to make your staffing adjustments. So that's where this new acuity tool is coming in. If hospitals are not following the staffing plan, these are some things that can happen. Lots of fines, and you have 60 days to provide a plan of correction if you do get fined. They increase if you fail to comply. And they increase on the second offense. IDPH will publicly disclose the violations. And the money will go to the Nursing Education Scholarship Fund, so they probably have no problem finding us because it's gonna go to a good cause. And this staffing plan, it says in here that nurses can safely report concerns. A nurse cannot be punished if they file a variance report, if they file a complaint against staffing. They cannot be punished for that. That is their voice. So, something that the Nurse Staffing Committee has been working on lately is trying to develop a new position for JCH, mainly to help out med-surg and ICU, but really it's for everyone. So really, to prevent burnout of the managers, we are trying to take off some workload of the manager's daily duty and put it on a new position of the full-time day shift supervisor. That way the manager can focus on their own manager duties from 7 to 3 while they're here. I've been following Julie for the past few weeks, and I know whenever she has that supervisor phone, she doesn't get to do a lot of her work sometimes. So this is a way for the supervisor to always be around, to not have to be held up in meetings. They are a dedicated person of support for the RNs and CNAs. On the busy days, on the days where nurses are stressed because they have a chest tube and they haven't had a chest tube in years, the supervisor can check on them more frequently because that supervisor is also not the manager. The supervisor can ensure adequate staffing for every shift. They would be the rapid response team leader, so they would always be around. We would not have to worry about someone being held up in a meeting or dealing with manager duties. This person can quickly respond to the rapid response. It would reduce the workload of the manager, and this person can also review patient's charts and ensure the needs of a patient, that the needs of the patient are met. That's a huge patient safety concern. Something that the supervisors do right now is that, so I work night shift, so I see this a lot. The supervisor will go through every patient's chart at the beginning of the shift. If this person's on Lovenox, is the Lovenox protocol in CPSI? That's a safety concern, and if it's not, then it needs to be. So the supervisor adjusts that at the very beginning of their shift. So this is something that the full-time day shift supervisor can be on top of as well. And a benefit of it is that it is continuity of care. The supervisor would be here every day from 7 to 3. So they're gonna know every patient that's here. They were here on Monday, they're still here on Friday. You're gonna know their whole story and why they're not getting to where they need to be, and maybe that's gonna be easier to communicate with doctors because you know more of the story than the nurse who just has them today. And it's an extra person to provide the education for things like CVIs, ventilators, chest tubes, things that we don't see a lot. If a nurse needs more guidance for that shift, they're just kind of stressed out, this is a person that they can go to for support. So examples of improper staffing: when the acuity and the patient number outweighs patient safety. For here, 10 plus medical patients with only 2 nurses, so technically 12 patients, we want 3 nurses for that. The 2 plus ICU patients with only 1 ICU nurse. With our nurses here, no nurse is going to be comfortable with more than 2 ICU patients. So we need to recognize that and staff accordingly. If it happens to where there's 2 ICU nurses and 1 happens to go home sick, there is no way that a CNA can come and fulfill that nurse's duties. Really, it's the supervisor who needs to come and be that second nurse with the ICU nurse until the end of the shift to make sure that all patients are safely taken care of. Including orientees and staff reading ratios, we talked about that. And if you staff reduce too many people because there's 2 patients on the floor, you run into the problem of not having enough patients for a code team. So as long as you have enough for a code team, that's okay, but we definitely need to keep that in mind when we're putting people on call and staff reducing. So variance forms, this is something that each RN can fill out. It's available to them to fill out. We keep it to where it's accessible to them and they don't have to be nervous to go walk and get one. If you did not get a lunch break that day, if you had an improper team assignment and you were not able to safely take care of your patients due to staffing, we want to know about it, and nurses can safely report these without being punished for them. And if one of these is filled out, we need to respond to it immediately. Supervisors need to respond to it that day, and we will definitely address all of them during our staffing meetings. That way, these complaints are being responded to in an appropriate amount of time. How to get more nurses involved: continue to meet monthly, stay on top of it, be open to outside suggestions, follow all the guidelines for the Nurse Staffing Improvement Act. Scheduling is a big one. We have day shift and night shift nurses in this committee, so scheduling can be hard, but we have to be accommodating, try to be accommodating to everyone. That way it's still open for everyone to join. And the committee is the idea of, or it's a way for the nurse's voice to be heard. If we stress that, we might get more RNs involved. Any questions? Can't think of any? And evaluations.
Lindsay, have you guys talked about how to, let's say a nurse comes only when they have a complaint to the meeting? Have you addressed like how many times they would have to come to a meeting before they could do a complaint? You know, like, you wouldn't want extra people to come only when they have a beef, you know?
Yeah, but also, I feel like that would, less people would join. If you say you have to show up to 3 before you can come with a complaint, that might limit how many people join. If you have a strong complaint and you want to come to the meeting, like, it's open for anyone to join. And if they're just for that meeting, if it's not a common thing where they just keep showing up and they keep having these complaints, but they don't come to the meetings, that would be something to address. But if it's just a few times, I would say let them come, because it's gonna encourage more people to come.
So at other places, they have like a 2-minute, you can talk for 2 minutes at the meeting, and then your item is completed, and you can either stay for the rest of the meeting and be silent about it, but you can't take over the meeting with your, you know what I mean? So you guys might wanna put something in there that says, if you're coming to do a complaint, you have a certain time frame, and you can stay for the meeting and or leave, but you have a time frame, because people could talk for hours on their situation.
Yeah, we would probably like try and restrict the time and just respect everyone else's time. If we stress that to them in the beginning, hopefully it wouldn't be an issue, but yeah, I definitely see what you're saying. That would be good to probably put in there. And evaluations, I will get to you guys, that way you can get them filled out. Any other questions? All right, thank you all for coming.